So troublesome symptom which impaired an individual quality of life or injury of complication in a result of regurgitation contact from the stomach to the esophagus and more upper part of initial part of gastrointestinal tract. Reflux-induced symptoms, erosive esophagitis, and long-term complication may have severely deleterious effects on daily activities, work productivity, sleep, and quality of life. All this damaging about the retrograde or regurgitation contact from the stomach to esophagus change the quality and the level of daily routine life of patient. By the Montreal definition of gastroesophageal disorder, state that troublesome symptoms may be considered to be from the moderate to severe symptoms that also occur on one or more days per week. And the severity and degradation of symptoms depends from the severity of damaging of the wall of the esophagus. So troublesome symptoms to be moderate or to severe symptoms and can range from the one-day symptoms per week or everyday symptoms per week. There are many theories about classification of the gastroesophageal reflux disease, but the last one, that gastroesophageal reflux disorder or disease can be classified relative to the presence or absence of erosions. And in the last edition of guidelines, we can separate it with you some special constitution like a non-erosive reflux disease or non-erosive reflux esophagitis, whereas gastroesophageal reflux disease symptoms with erosion constitute erosive esophagitis. So non-erosive reflux disease or NERD and erosive esophagitis like a next stage of gastroesophageal reflux disease. It should be emphasized that erosion esophagitis can also occur in the absence of symptoms. Erosion and non-erosion reflux disease can be in the presence of symptoms and can be without any clinical picture, clinical symptoms. Non-erosion reflux disease has been defined specially as a subcategory of gastroesophageal reflux disease, which characterized by also troublesome reflux-related symptoms in the absence of esophageal mucosal corrosions or esophageal mucosal damaging at conventional endoscopy and in the absence of recent acid suppressive therapy. And in that absence of erosions, it's indication for absence of recent acid suppressive therapy. This definition from the guidelines was further qualified on the basis of pathobiology and diagnosis with the statement that evidence in support of this diagnosis includes, but is not limited to responsiveness to acid suppression and positive 24 hours pH monitoring or identification of specific northern endoscopic, morphological or physiological findings. And non-erosion reflux disease is by far the most common form of gastroesophageal reflux disease globally, totally in the population. Next point in classification, we discussed with you non-erosive reflux disease, erosive esophagitis, next stage of damaging, and next point in classification is Barrett's esophagus. Barrett's esophagus refers to the endoscopic presence confirmed histologically of column-lined esophagus under the influence regurgitatable contents of the stomach, which including hydrochloric acid, due to chronic damage in the lower part of the esophagus started to change and changing the type of epithelium in the stomach in the esophagus and changing to the columnar line esophagus. It's already metaplasia. This is currently the only identifiable complication of gastroesophageal reflux disease that is known to have malignant potential. And unfortunately, Barrett's esophagus we can describe with you like a precancer form to adenocarcinoma of esophagus. So from the one side, it's next stage of gastroesophageal reflux disease. From another side, it's already metaplasia and its complication of gastroesophageal reflux disease and its precancer form till adenocarcinoma of the esophagus. Extraesophageal symptoms of gastroesophageal reflux disease can be categorized as a condition that had an established association with symptoms of gastroesophageal reflux disease and the nature of gastroesophageal reflux disease. What it is extraesophageal syndromes? It's a cough, chronic cough, which is associated with regurgitation through the esophagus till the oral cavity and next going to the trachea and association with symptoms gastroesophageal reflux disease. Laryngitis, it's also a chronic damaging due to contact of the stomach, which including hydrochloric acidity. Asthma and asthma symptoms which associated with gastroesophageal reflux disease, and dental erosions and damaging of the dentine, and those that have only proposed association, pharyngitis, sinusitis, idiopathic pulmonary fibrosis, and otitis media. Very rare otitis media, but it can be also extrapharyngeal syndromes of gastroesophageal reflux disease, absolutely with the same nature, about regurgitation contents from the stomach through the esophageal till the oral cavity. Some words about epidemiology of gastroesophageal reflux disease. Surely it's a global disease, and evidence suggests that its prevalence is increasing. Prevalence estimates show considerable geographic variation, but it's only in East Asia that prevalence estimates are currently constantly lower than 10%. The high prevalence of gastroesophageal reflux disease and hence of troublesome symptoms has significant societal consequences, impacting adversely on work productivity and many other quality of life aspects for individual patients. Most epidemiological studies of the condition are symptom-based, as symptom-based diagnosis is challenging and the epidemiological data on the prevalence of gastroesophageal reflux disease are probably flawed. And nonetheless, that it's instructive to report the prevalence of dyspeptic symptoms across the globe. As the data affect the protest probability, the upper gastrointestinal symptoms are attributed to gastroesophageal reflux syndrome or disease. And in all cases of discussing gastrointestinal disorders, we will discuss with you dyspeptic syndrome. But we have to understand that these varieties of dyspeptic syndrome will be different in case of esophageal disorders, in case of liver damaging, in case of damaging of the pancreas and gallbladder by the stones. Surely, for developing such condition like gastroesophageal reflux disease, we have to know with you and the patient can have some predisposing social or risk factors for developing gastroesophageal reflux disease. In fact, gastroesophageal reflux disease it's a sensory motor disorder which is associated with impairment of the normal anti-reflux mechanism. In fact, it's some problems with tonus of lower esophageal sphincter function and phrenic esophageal ligament. Closing mechanism of closing may be too much dilatation due to achalasia of the cardia, but key problem is a lower esophageal sphincter with changes in normal physiology. Impaired esophageal peristalsis can be increased intragastric pressure, increased abdominal thoracic pressure gradient and increase intra-abdominal pressure, or more rarely, excess gastric acid secretion in case of Zollinger-Ellison syndrome. It's a gastrinoma, it's a tumor which located more often in the head of the pancreas and producing gastrin, which stimulated production of the hydrochloric acid by the parietal cells. So we can categorize with you predisposing factors for group: eating and lifestyle, medication, pregnancy, and some other factors. We'll start from eating and lifestyles. An increase in gastroesophageal reflux disease symptoms occur in individuals who gain weight. A high body mass index is associated with an increased risk of gastroesophageal reflux disease. High dietary fat intake is linked also to a higher risk of gastroesophageal reflux disease and erosive esophagitis. Taking herbonate drinks are a risk factor for heartburn during sleep in patients with gastroesophageal reflux disease. Look, in fact, increase in large body mass index associated with increased intra-abdominal pressure. High dietary fat intake food is associated with hyperproduction of hydrochloric acid to reduce all this fatty food. And herbonate drinks and taking it associated with not hyperproduction, it's a presence additional gas which needed to go out through the lower esophageal sphincter, through the oral cavity, and can lead with it acidity content from the stomach. About the role of coffee as a risk factor of gastroesophageal reflux disease is unclear. Coffee may increase heartburn in some gastroesophageal reflux disease patients, but coffee is not a dominant and separately risk factor. We can't associate it only taking and drinking a coffee like the main host factor in developing gastroesophageal reflux disease. It's not the main, it's not the dominant, and separately only coffee can lead to developing gastroesophageal reflux disease. But we knew that the caffeine can change the tonus of lower esophageal sphincter. About role of alcohol consumption as a risk factor of gastroesophageal reflux disease also is unclear, but excessive long-term use may be associated with progression to esophageal malignancy due to chronic damaging of ethanol of the mucous membrane of the esophageal, direct damaging action, but this may be independent of an effect of alcohol on gastroesophageal reflux disease. Also, we knew that alcohol consumption associated with the moment and the time of losing of consciousness, and it can be a reason of losing control of our esophageal sphincter and can be a reason of regurgitation content into the lumen of the esophagus. Role of smoking as a risk factor for gastroesophageal reflux disease also is unclear, but although like alcohol, it's associated with an increased risk of malignancy. And the typically portrait of a patient with adenocarcinoma of the esophagus, like a last stage of gastroesophageal reflux disease, and in fact it's big problem, malignization, gastroesophageal reflux disease till Barrett's esophagus until the adenocarcinoma, and typically portrait that it's a man in the age more than 55 which taken alcohol and who smoked, and also who had a level of heredity in the presence of adenocarcinoma of the esophagus. So, by the last medical research, not established the dominant role of the coffee, of alcohol, of smoking, but alcohol and smoking increasing ability to malignization, Barrett's esophagus to adenocarcinoma. About taking some medication by our patient and association with developing gastroesophageal reflux disease. The treatment of comorbid conditions, for example, it's arterial hypertension, treatment with calcium channel blockers, because the main mechanism of calcium channel blockers, it's dilatation of smooth muscles and lower esophageal sphincter composed also by the smooth muscles and can relax under the activities of calcium channel blockers. Anticholinergetics, medication, the same mechanism, and non-steroidal anti-inflammatory drugs. There is some another mechanism, it's blockage COX-1 till COX-2, decreasing in the synthesis of prostaglandins, and stimulation of production of hydrochloric acid T. In other medication, for example, bisphosphonates, antibiotics, potassium supplements may cause upper gastrointestinal tract injury and exacerbate reflux-like symptoms or reflux-induced injury, can worsening the condition on the base of gastrointestinal reflux disorder. Next group of host factors, pregnancy. Eating and lifestyle, we discussed with you types of medication and points of medication. Next point, pregnancy. Heartburn during pregnancy usually does not differ from the classical presentation in the adult population without pregnancy, but it worsens as pregnancy advanced. And this regurgitation occurs with approximately the same frequency as heartburn and gastroesophageal reflux disease. In the first trimester is associated with a number of altered physiological response. And in fact, pregnancy, like a host factor, contacted associated with increasing intra-abdominal pressure in the second and the third trimester of pregnancy. Factors that increase the risk of heartburn are heartburn before the pregnancy, increase in worsening situation, parity, and duration of pregnancy. Maternal age is inversely correlated with the occurrence of pregnancy-related heartburn. And the last group of predisposing factors is other pathological factors. The high incidence of gastroesophageal reflux disease in cousins is likely to be related to lifestyle rather than genetic factors. Comorbidities are frequent in patients with gastroesophageal reflux disease. Diabetes, metabolic syndrome, cardiovascular disease, and sleep apnea are all common and aggravated conditions in the patient with gastroesophageal reflux disease. And overweight and obesity are common risk factor both for gastroesophageal reflux disease and for these other comorbidities. All comorbidities form like a background aggravated in patients with gastroesophageal reflux disease by many reasons. For example, by taking non-steroidal anti-inflammatory drug, for example, by taking channel blockers medication in case of arterial hypertension, in case of heart failure, and obesity like a primary factor. Gastroesophageal reflux disease frequently coexists with other gastrointestinal syndromes, such as irritable bowel syndrome. In Japan, for example, osteoporosis with vertebral fractures and kyphosis is widely considered to be one of the risk factors for erosive esophagitis due to change in normal anatomy of the mediastinum of the chest, and especially among elderly women, and when severe, this skeletal condition have been associated with Barrett's epithelium, Barrett's esophagus. And look to our scheme about pathogenesis and clinical findings association with the gastroesophageal reflux disease. Look, we can separate it clinically. Primary gastroesophageal reflux disease, which causes nature, which we discussed yet, and secondary gastroesophageal reflux disease about some another nature, but problem will be absolutely the same. Look, primary gastroesophageal reflux disease, increasing intra-abdominal pressure in case of obesity, in case of pregnancy, in case of maybe some surgery intervention on the abdominal cavity, which can be a cause of increasing intra-abdominal pressure. In case of ascites, in case of liver failure, it also can be a reason of increasing intra-abdominal pressure. Some foods which we discussed: coffee, alcohol, chocolate, meat, fatty meals, spicy, citruses, drugs, beta-agonists, calcium channel blockers, anticholinergics, non-steroidal anti-inflammatory drugs. Increase in intra-abdominal pressure leading to development of hiatal hernia. It's a portion of the stomach can protruding above the level of the diaphragm into the chest cavity, changing the normal anatomy, no balance, no normal working of lower esophageal sphincter, the reason of regurgitation context of the stomach to the esophageal. Lower esophageal sphincter still has structural some supporting. Foods and drugs leading to abnormal lower esophageal sphincter relaxation, changing the tonus of lower esophageal sphincter, leading to excessive or prolonged transient lower esophageal sphincter relaxation. More longer time for relaxation, ability for regurgitation. About secondary gastroesophageal reflux disease. For example, scleroderma, like autoimmune disorder with developing connective tissue in the wall of the esophagus, not only wall of the esophagus, separately changing the connective tissue, also including in the structure of the esophagus. Large meal, delayed gastric emptying, scleroderma leading to collagen depositing around the body, including lower first part of the esophagus. Decrease in peristalsis cause connective tissue fibrosis, leading to decrease normally functional peristaltic of esophagus, leading to problems with tonus lower esophageal sphincter. Large meal, delayed gastric emptying, leading to gas builds up into the stomach, increasing pressure in the cardiac part, leading to pressure receptor indirectly stimulated the nevi vagi, leading to vagus nevi, stimulated lower esophageal sphincter relaxation. Parasympathetic leading to relaxation, sympathetic to constriction. So stimulation of nervi vagi leading to more longer time of relaxation, lower esophageal sphincter. So problem with closing, problem with normally physiology, more longer period of relaxation. It's leading to that hydrochloric acid in the stomach can be regurgitated up by increasing intra-abdominal pressure, exercise, obesity, pregnancy, or positional changes during lying down, during horizontal position. Regurgitation in the lower part of esophagus. Look, condition associated with increasing in large level of acid production. Peptic ulcer also associated with regurgitation, this context which endurance of the hydrochloric acid to esophagus. Okay, regurgitation like effect. It's leading to repeated damaging of esophagus, of esophageal mucus, leading to normal squamosous epithelium, like a mucosa of esophagus, replaced with the columnar cells and its metaplasia. It's Barrett's esophagus, like a pre-cancer form, like a pre-cancer lesion, leading to over time may progress to adenocarcinoma. And look, one patient from 1,000 will be diagnosed adenocarcinoma with normal level of treatment Barrett's esophagus or gastroesophageal reflux disease. Repeated damaging of the esophageal mucosa leading to scarring can from esophageal structure can lead into bleed and can lead into bright red hematemesis and to mechanical dysphagia, absolutely with the solid food. Clinical features from the side of the patient. Also, this chronic damaging leading to development heartburn sensation, epigastric and classically retrosternal burning sensation, may persist despite treatment, non-erosive reflux disease. So heartburn can be clinical signs, not only erosions, can be signs in the absence of the erosion. Also, it's leading to acid regurgitation or water breath, can lead into aspiration of acid into larynx, inside the trachea, inside the lungs, irritation of upper respiratory tract, and can be a reason of chronic cough, especially at night, signs of asthma, and signs of hoarse voice. Surely this regurgitation to oral cavity can be a reason of damaging of the teeth, damaging of the dentine of the teeth, and sometimes this changing in the structure of dentine will be first sign of gastroesophageal reflux disease. So, clinical symptoms. Gastroesophageal reflux disease has a wide spectrum of clinical symptoms and based and injury-based presentation, which may manifest either separately or in combinations. Heartburn and regurgitation are the cardinal and most common symptoms of gastroesophageal reflux disease, but the definition and the relative prevalence of heartburn and regurgitation may vary regionally. Regurgitation may indicate gastroesophageal reflux, but it can occur with other less common conditions such as obstruction or echinoesophageal. So regurgitation is not only specific symptom of gastroesophageal reflux disease. Regurgitation should be distinguished from rumination. Rumination is the effortless regurgitation of partially digested food into the mouth through the esophagus also, with the exception of further mastication and swallowing. Rumination is a type of behavioral of patient. Heartburn, it's a retrosternal burning sensation feeling that may move upward toward the neck and throat, and it may coexist with other symptoms referable of the upper gastrointestinal tract. Heartburn can be a part of dyspeptic syndrome. Heartburn may be accompanied by regurgitation of sour acid tasting fluid or gastric contents into the mouth, or the back of the throat, acid or food regurgitation. In practice, there may be no clear differentiation between that are regarded as gastroesophageal reflux disease symptoms and dyspepsia, broadly defined as symptoms felt in the upper abdominal. Sometimes patients cannot differentiate it and will tell you about some uncomfortable feelings in the upper part of the epigastrium, in the upper part of the abdominal, and closer to sternum. The Canadian Dyspepsia Working Group defined dyspepsia or dyspeptic syndrome as a symptom complex of epigastric pain or discomfort thought to originate in the upper gastrointestinal tract. That may include any of the following symptoms: heartburn, acid regurgitation, excessive burping and belching, increased abdominal bloating, nausea, feeling of abdominal or slow digestion, or early satiety. An endoscopic study in patients with uninvestigated dyspepsia revealed that esophageal findings, predominantly erosive esophagitis, were more commonly seen in patients whose reflux symptoms, heartburn and regurgitation. It's logical, it's clear. The most troublesome. However, the prevalence of gastric and duodenal findings were comparable in patients with reflux, ulcer, and dysmotility symptoms. We can differentiate with you gastroesophageal symptoms for absolutely typical for GERD and atypical symptoms, but not exclude gastroesophageal reflux disease. Typical, it's heartburn, daytime or nighttime with contact with the lying down. Regurgitation, daytime or nighttime, and water breath or hypersalivation. You knew that the saliva, it's a main hydrocarbonate, and in case of increasing acidity, increasing production of the saliva to reduce acidity of the contents of the stomach. Typical symptoms: atypical, nausea, eructation or belching, slow digestion or early satiety, epigastric pain in the upper part of the abdominal chamber, bloating, vomiting, chest pain, precardial pain, respiratory symptoms, cough, wheeze, chronic rhinosinusitis, extraesophageal symptoms, hoarseness, pharyngeal pain, globus, early awakening due the regurgitation due the early heartburn, nocturnal awakening, and nightmares. For example, epigastric pain can be associated with peptic ulcer, not only with gastroesophageal reflux disease. Chest pain can be associated with coronary heart disease. Early awakening can be associated with bronchial asthma and with coronary heart disease. Nocturnal awakening can be associated with bronchial asthma. Atypical, but this symptom also can be symptoms of gastroesophageal reflux disease. About anamnesis of the patient with gastroesophageal reflux disease. Most cases of GERD are mild and are not associated with a significant increase in morbidity and mortality in comparison with the general population. And in most population patients with gastroesophageal reflux disease, the severity of the condition remains stable or improves after a 5-year observation period during current routine clinical care. Also, there is a closer relationship between the gastroesophageal reflux disease and obesity. And we discuss it like a host factor. A high body mass index or larger waist circumflex during your measurement, during your routine examination, and weight gain are associated with the presence of symptoms and complications of gastroesophageal reflux disease, including Barrett's esophagus like a precancer form. Complicated gastroesophageal reflux disease is characterized by structure, Barrett's esophagus, and esophageal adenocarcinoma. And the last Montreal consensus includes erosive esophagitis as a complication of gastroesophageal reflux disease, recognizing that the definition of mucosal breaks used in the Los Angeles classification includes esophageal ulceration in the range of reflux esophagitis. So the last preview of guidelines included erosive esophagitis in the zone of complication of gastroesophageal reflux disease because it's associated with development adenocarcinoma. Non-erosive reflux disease may progress to erosive esophagitis in approximately 10% of cases, and erosive esophagitis may therefore be considered as a manifestation of more severe reflux disorder. Erosive esophagitis is associated with Barrett's esophagus, and it's a major risk factor for development Barrett's esophagus. In fact, we can start from non-erosive reflux disease disorder and without normal level of treatment, without changing the weight, without changing of lifestyle, we can continue till the Barrett's esophagus like a precancer form. In comparison with patients who were free of gastroesophageal reflux disease at follow-up, those with esophageal erosive esophagitis had a 5-fold increased risk in Barrett's esophagus after 5-year presence diagnosis of erosive esophagitis. In the cohort of the general population, its medical research was established in Sweden, but it's a general knowledge. It's not known that when Barrett's esophagus develops relative to the ones that of gastroesophageal reflux disease, and however, it appears to be more prevalent in older individuals, and it's strongly associated with an increased risk of esophageal adenocarcinoma. There is a well-documented association between body mass index and adenocarcinoma of the esophagus and gastric cadence, although the risk of malignancy in a given individuals with gastroesophageal reflux disease is very low. Alarm features from the side of clinicist. In fact, in case of assessing the condition of the patient with gastroesophageal reflux disease, we can find with you and we can pay attention to some alarm features in case of diagnostic process. The most alarm features are not specific for gastroesophageal reflux disease, and we will discuss it with you practically in our description. But many are associated with alternative diagnoses that are unrelated to gastroesophageal reflux disease. In most countries, many of these features relate to gastric cancer, complicated ulcer disease, or other serious disease. It's dysphagia during solid food. It's alarm features. It can be a sign of tumor growing. Odynophagia of painful during swallowing. Recurrent bronchial symptoms. Recurrent aspiration pneumonia. Dysphonia. Recurrent of persistent cough. Gastrointestinal tract bleeding, frequent nausea and/or vomiting, persistent pain, iron deficiency anemia, progressive unintentional weight loss or unmotivated weight loss, lymphadenopathy, epigastric mass, new onset atypical symptom in patients with age between 35 and 55 years. Allow age threshold may be appropriate depending on local recommendation, and family history or either esophageal or gastric adenocarcinoma and the level of heredity from the patient. In fact, all these problems are general, but also we should pay our attention to these features in case of gastroesophageal reflux disease and make an alternative diagnosis. It's better for patient if we'll exclude all problems and confirm our diagnosis gastroesophageal reflux disease. About patient history. The goals of patient evaluation include the assessment of symptoms and risk factors, which we discussed for the diagnosis of gastroesophageal reflux disease, and the prediction of long-term sequelae. Some personal and family history features. The following features may be helpful in making and putting a diagnosis and assessing the severity of gastroesophageal reflux disease for us like a clinicist. Predisposing factor and risk factors, including family history, duration of symptoms, very important, the time of onset of symptoms. Daytime symptoms, including time of day and relationship with the meal. Nighttime symptoms, including impact on sleep and the effect of the recumbent position or large, late evening meals and contact with the change in position to the lying down and contact with the late taking a meal. Treatments and remedies tried, including symptomatic response to therapy, symptom improvement with acid-lowering medication, including antacids, supported diagnosis of gastroesophageal reflux disease, and we can make a test with taking antacids. Periodic dysphagia or food bolus infection may suggest reflux-related esophageal injury, structure or malignancy, as well as eosinophilic esophagitis or esophageal dysmotility. We need to assess a drug history of our patient, acetylsalicylic or non-steroidal anti-inflammatory drug, iron, potassium, quinidine, tetracycline, biphosphonates, which all this medication leading to change in tonus of our esophageal sphincter. Zidovudine, anticholinergic agents, alpha-adrenergic agonist, barbiturates, leading to change in acetylcholine receptors in the central nervous system. Beta-2 adrenergic agonist, calcium channel blockers, benzodiazepines, dopamines. Also, we need to assess a history about taking such hormones like estrogen in case of treatment of a woman population. Narcotic analgesics about the loss of consciousness, loss of control. Nitrates, like a specific smooth muscle dilatation, included low esophageal sphincter. Progesterone, prostaglandins, which increasing secretion of hydrochloric acidity, tricyclic antidepressants, and chemotherapy, which can be a reason of direct damaging action on the structure of the esophagus. We need to pay attention to dietary history. In some patients, bloating or constipation may be associated with increasing risk of gastroesophageal reflux disease or syndrome due to increasing intra-abdominal pressure about constipation. Several studies suggest that stopping smoking and some physical measures, as well as modification of meal size and timing, can be beneficial, but there is limited evidence for the avoidance of alcohol and certain dietary ingredients, including canned drinks, caffeine, fat, spicy food, chocolate, and meat. In those who are overweight, weight loss may be associated with improvement in gastroesophageal reflux disease and improvement from gastroesophageal reflux syndrome. And fermentable carbohydrates may increase the propensity for reflux. So, levels and points during physical examining of patient in case of gastroesophageal reflux disease. We need to measure waist circumflex, wave, and assess body mass index to assess the predisposing factors. We need to pay our attention to peripheral stigmata of scleroderma, may rarely but can be present. Evaluation and inspection to exclude other medical problems such as asthma, cardiac disease, and cancer. Maybe this troublesome symptom will contact with the chronic coronary disease. Maybe this nighttime cough will contact with the bronchial asthma. We need to exclude these one problems. Physical evaluation and the signs of clinical signs of anemia and weight loss. From the side of oropharynx, ulceration, candidates on the base of ulceration, lesion, masses, lingual dental erosions, caries, like a sign of regurgitation, acidity. On the side of the neck, some lymphadenopathy, we need to palpate lymph nodes and masses. From the side of the lungs, we can diagnose with you in case of extraesophageal conditions, wheezing, some crackles, and the base of aspiration pneumonia. From the side of the ears, hearing loss due to regurgitation through the eustachian tube. Middle ear effusions, evidence does not support gastroesophageal reflux as a cause of otitis media. From the side of abdomen, masses and tenderness. Signs or local or systemic of malignancy, returning to alarm features, if history and examination are suspicious. For example, clinical signs of anemia, it's a systemic signs of malignancy, returning to the malignancy alarm features. Maybe you round it about compliance of the patient, and the patient tell you about some dysphagia and problems with the swallowing of the solid food. About diagnostic tests for gastroesophageal reflux disease. A presumptive diagnosis of gastroesophageal reflux disease can be established on the setting of typical symptoms, heartburn and symptoms of regurgitation. Typically symptoms and the main heartburn and regurgitation, daytime, nighttime symptoms. In pregnancy, gastroesophageal reflux disease can be reliably diagnosed on the basis of symptoms alone. In the dominant or most troublesome symptoms are atypical for gastroesophageal reflux disease, other diagnoses should be considered, including Helicobacter pylori associated disease and non-steroidal anti-inflammatory drugs-induced symptoms. In regions with a high prevalence of hydrochloric pylori infection, an initial hydrochloric pylori tests and treat strategy or endoscopy, if available, should be considered. So, radiological examination are seldom required. Esophageal pH or pH impedance monitoring and esophageal manometry can be performed safely, but are seldom required. And intractable reflux symptoms of gastroesophageal reflux disease complication can be evaluated safely using fibrogastric duodenoscopy. Upper gastrointestinal endoscopy and fibrogastriduodenoscopy is not required in the presence of typical gastroesophageal reflux disease symptoms, and despite the high specificity of a finding of esophageal erosions or mucosal breaks for the diagnosis of gastroesophageal reflux disease. Endoscopy is recommended in the presence of alarm features, alarm symptoms, and for assessment of patients who are at high risk for complication of other diagnoses. Recent dates indicate that it's reasonable to perform endoscopy to screen for Barrett's esophagus in certain high-risk groups, in particular overweight, white males under the age of 30 with chronic gastroesophageal reflux disease symptoms had an increased risk of esophageal adenocarcinoma. And if we look to this picture, we can assess with you different pictures due to fibrogastriduodenoscopy. We can find, look for example, it's ulcers on the base of metaplasia. It's only visual photos. It's a stricture of esophagus. It's a Barrett's esophagus, precancer form. It's different stage of erosive esophagitis, but also with element of metaplasia. Practically healthy esophagus, histological examining, Barrett's metaplasia, Barrett's esophagus, changing to the columnar epithelium, histological result, and esophageal adenocarcinoma. But look, around practically healthy mucosal cover. Surely, if we continue this fibrogastriduodenoscopy, we should take in biopsy materials for pathological study. And biopsies may be taken from the esophagus, from the stomach, or duodenum. Distal esophageal biopsy are not recommended for diagnosis gastroesophageal reflux disease. Upper part of the esophagus not recommended for diagnosis and should not be taken unless once of evaluating for complication of eosinophilic esophagitis. If you need to exclude eosinophilic nature of esophagitis, you can take a sample from the distal part also. Gastric biopsy should be taken in order to diagnose of Helicobacter pylori infection, because we discussed with you that presence Helicobacter pylori associated not only with peptic ulcer but also associated with gastroesophageal reflux disease. Atrophy, intestinal metaplasia or dysplasia, even in the presence of erosive esophagitis. It should be recognized that biopsy may be false negative for Helicobacter pylori if the patient are taken or have recently taken proton pump inhibitors or antibiotics in scheme of eradication therapy due to Helicobacter pylori. There is no role for routine duodenal biopsy in patients with typically gastroesophageal reflux disease symptoms. Which test for Helicobacter pylori infection we have to do with you? Urea brief testing of Helicobacter pylori, stool antigen testing, breathing test quickly, urea brief testing, and stool antigen testing are recommended as like a non-invasive test for active Helicobacter pylori infection as a basis for a test and treat strategy for Helicobacter pylori in regions in which the prevalence of Helicobacter pylori exceeds more than 20%. Helicobacter pylori testing does not confirm or exclude of diagnosis of gastroesophageal reflux disease, but we can confirm presence of Helicobacter pylori. But in line with the cascades approach, the diagnosis of gastrointestinal symptoms should be guided by local disease prevalence and economic factors. Urea test, brief testing, stool antigen testing for Helicobacter pylori non-invasive. Serology. Serology is suboptimal for the diagnosis of active Helicobacter infection, but in regions with high prevalence, and particularly if the patient has not taken antibiotic recently, serology will still have a reasonable high positive predictive value if locally validated. Helicobacter pylori serology may provide guidance in patients who taken proton pump inhibitors therapy, and which can lead to false negative test of active infection. Helicobacter stool antigen test, histology, culture, or epithelial test. Esophageal manometry, like a functional diagnostic methods, esophageal manometry is recommended for pro-operative evaluation before the surgery intervention if you assess an indication for surgery intervention problems for gastroesophageal reflux disease patients. Before anti-reflux surgery or for patients with persistent symptoms despite adequate treatment and a normal endoscopy, to rule out and to exclude achalasia or other motility disorders. No absolutely endoscopic signs like erosions, but persistent symptoms of gastroesophageal reflux disease. Esophageal manometry has no role in the routine diagnosis of gastroesophageal reflux disease, but we confirm the presence problem with the tonus of the lower esophageal sphincter. It's also endoscopy. It's invasive method. We output with endoscope with flexible tube, the manometer exactly inside the lower of lower esophageal sphincter. We can do it routine one time, or we can do it daily. It's not so comfortable, but it's not so trouble for patient. And we can monitoring and assess manometry of lower esophageal sphincter and make a conclusion about problems with dilatation, increasing duration time with dilatation lower esophageal sphincter. Esophageal pH-metry. Ambulatory esophageal pH-metry and impedance may help evaluate patients who are refractory and no answer for proton pump inhibitor therapy, and when the diagnosis of gastroesophageal reflux disease is in question. No positive effect after proton pump inhibitor therapy. Question about our right diagnostic. Ambulatory reflux monitoring with pH-metry is the only test that can assess reflux symptom association. And esophageal pH monitoring is indicated before considering anti-reflux surgery for gastroesophageal reflux disease, and usually with the patient of therapy, in order to confirm that the symptoms are indeed reflux related. It's practically the similar devices, yes, but more smaller intranasal tube continue through the oral cavity till the lower third part of esophagus above the lower esophageal sphincter, where to assess it during 24 hours due to 24 hours pH-metry to assess the level of acidity and the time of reflux, timing of reflux. And like a conclusion, we can assess with the really timing of refluxes or regurgitation of acidity, because some refluxes during the time it's normal for healthy person. Next moment in the diagnostic, barium radiography. Barium radiography of swallow or meal should not be performed in diagnosis gastroesophageal reflux disease. Barium radiography may be appropriated in patients who have ancillary symptoms of dysphagia in order to assess structural disorders, for example, hiatal hernia, malrotation, or mobility disorders like achalasia of the cardia. Barium radiography, it's a gray, not native, it's X-ray with the barium. And for example, such X-rays, gastroesophageal junction on the first, hiatal hernia, and a part of the stomach inside of the chest, and diaphragmatic constriction. On another part, hiatal hernia again, Hiatal hernia is a predisposing factor for developing gastroesophageal reflux disease due to change in anatomy of the esophagus, lower esophageal sphincter, and stomach. Look how interesting, big size of hiatal hernia, and not practically all the stomach mirroring, protruding to the chest, mirroring, and it's really stomach inside the chest. Where is esophagus? Contrasting in the esophagus. Surely it's a big problem for patients. Surely it's a predictor for developing not only esophagus, for problems with the stomach, problem with the ingestion. Contrast like a barium above the level of diaphragm in the cardiac part. Gastroesophageal reflux disease or gastroesophageal reflux syndrome, it's an important part of alternative diagnosis, differential diagnosis for patients. We need to differentiate it with peptic ulcer disease in case of presence Helicobacter pylori, but we should know that peptic ulcer, which is associated with Helicobacter pylori, increasing ability of developing gastroesophageal reflux disease due to increasing acidity. Upper gut malignancy, some functional heartburn, differentiate non-erosive reflux disease and functional heartburn on the basis of a clinical response to therapeutic acid suppression, pH monitoring or impedance pH monitoring, achalasia of the cardia, esophageal body motility disorders due to systemic problem, due to scleroderma, diffuse esophageal spasm. We need to differentiate it in case of eosinophilic esophagitis, like a part of eosinophilic problem, including bronchial asthma. Infection, for example, candida, and such visual picture due to Barrett's esophagus can also associated with the candida. Visual practically they're similar, but in case the candida, we can assess with you some upper gut above the normal mucosal of esophagus. Pill esophagitis, which is associated with taking medication. Cardiac disease, ischemic heart disease, and precardial disease due to closer relationship with innervation of blood supply, due to the similar localization of the heartburn sensation and the heart attic, which is associated with coronary genesis. Esophageal diverticulum also can be a cause of dyspeptic syndrome and heartburns, and in other chest pathology, including bronchial asthma, including some problems with the lungs, including tuberculosis with damaging of the diaphragm, and many other pathologies which can be a cause of gastroesophageal reflux syndrome. So not so long today.